Motor neurone disease can often be difficult to diagnose due to its multifaceted presentation. I'm a trained physician with over 20 years of clinical experience, and yet I failed to pick this up in my father, who passed away with this condition in August 2022. So here, I would like to present his case presentation, especially focusing on the signs that I had missed, so that you may be able to identify these signs and diagnose the condition early. So, my father was a fit, active, healthy gentleman who had controlled hypertension and dyspepsia. When he started losing weight disproportionately to his diet in about the spring of 2021, by September he had developed severe constipation, which was really abnormal for him, requiring multiple enemas. At the same time, he also was noted to have hyponatremia, and this was thought to be due to the PEG laxatives that he had and the diuretics, which had both stopped, but he had a further such episode which was just symptomatically treated. To investigate his significant weight loss and constipation, he was checked out for bowel cancer and had extensive investigations which were normal. He was then told to have irritable bowel syndrome. However, his symptoms continued to increase with bloating and anal incontinence. At about this time in November that year, I noticed he had developed abnormal paradoxical breathing, but failed to connect this with a neurogenic cause. He also had cocking of his shoulders, perhaps due to the hyperactivity of the accessory muscles of respiration. I'm not sure, but he did have intercostal retraction. I also saw him to have open mouth breathing while asleep. And this again, many seniors have, and this can be seen in people with blocked air passages. But in his case, it was due to increasing jaw muscle weakness, which again, I had failed to connect. And then he also had a weak cough and a weak burp. These were early signs of diaphragmatic dysfunction. Motor neurone disease can rarely directly affect the respiratory muscles. He had further investigations at this point in time, and because he had a retrosternal mass, he was checked out for myasthenia gravis. Test came back negative. He now had chewing problems, and this was thought to be due to his poor dentition. His dentures were changed. He had several dental extractions, but again, this did not help. Again, as the symptoms progressed, he started complaining of his dentures becoming heavier and heavier. Another symptom that I noticed was he kept asking for more fans, and his sleep had altered. He had daytime somnolence. Abruptly, he will fall asleep during the day. This was because of the building carbon dioxide in the blood, increasing respiratory failure and respiratory weakness. His symptoms continued to deteriorate, and he had a further episode of hyponatremia. His bloods at that time showed low albumin, a bit of anemia, perhaps because of the malabsorption in his gut. But also, there was always an uptick of the bicarbonate. And again, I couldn't pinpoint it at that time. So the bicarbonate and then the recurrent low sodium, euvolemic hyponatremia. He continued to grow weaker, and I noticed that his speech was slurred, and he himself told me it was not because of the lack of usage of dentures, but because of something else. And then his head began to drop one day. That same night, he was admitted to ICU comatose. I was noted to have not only severe hyponatremia, but also compensated metabolic alkalosis on top of severe respiratory acidosis. His carbon dioxide was more than 10. Even at that point, his diagnosis was not established. He had further investigations, 2 nerve conduction studies, and only at the second nerve conduction study, when I told the neurophysiologist that I had noticed a head drop, then motor neurone disease was diagnosed. And this was not the standard motor neurone disease, it was the most aggressive form. He even had further tests for his retrosternal mass, considering a possibility of a paraneoplastic condition. But again, this was then found to be a retrosternal thyroid, so a paraneoplastic condition was ruled out. So, in the end, this was a most aggressive form of motor neurone disease, unfortunately. And in 2 weeks, he passed away with not only respiratory failure, but also further precipitating gastroenterological complications. So here I don't want to dwell on that part, but more so on the many features he demonstrated on his way towards that end stage. So please remember, 1. Gastroenterological manifestations can be the only format motor neurone disease can first present. 2. A neurogenic cause of paradoxical breathing. 3. Early signs of diaphragmatic dysfunction such as a weak cough or a weak burp. 4. He can have subtle signs such as asking for more fans or sleep disturbance. 5. He can have altered electrolytes such as a high bicarbonate indicating an occult respiratory acidosis and a compensated alkalosis. A blood gas could be helpful. And also look out for open mouth breathing, jaw weakness. So until we have a cure for motor neurone disease, it is essential that we do diagnose this condition early, and I sincerely hope this video will help some of you somewhere in diagnosing motor neurone disease. Thank you.